Dr. Kamath today. Dr. Kamath is an advanced heart failure and transplant cardiologist here at UCLA. Dr. Kamath is originally from the Midwest, completed her medical training at Northeast Ohio Medical University. Upon completion of her residency at Summa Health System and General Cardiology Fellowship at Allegheny Health Network, Dr. Kamath came to UCLA for Advanced Heart Failure Fellowship and has been on faculty since. She is active in clinical care, research, medical education, with particular interest in cardio-obstetrics and women's cardiovascular health, cardio-oncology, and disparities in heart transplantation. Dr. Kamath, thank you so much for giving us ground rounds today.
Thank you so much for the kind introduction, Patrick, and thank you everyone for being present here and the opportunity to speak today. I hope everyone's staying safe and healthy with all of the respiratory viruses going on around at this time of year that I think forced us to pivot to a virtual only option. But I'm excited nonetheless to present a topic that has been really fascinating to me and an area in cardiovascular medicine where there just continues to be tremendous growth and new knowledge. So we'll talk about cardio-obstetrics through the lens of cardiomyopathy and where we are now in January of 2024. So I do not have any disclosures related to the content of this talk. And we'll go ahead and get started with a case presentation. So this is somebody that we're currently seeing at UCLA. So some of you may be familiar with this patient, but she is let me go back there for a moment. She is a 36-year-old female, G2P0 at 34 weeks and 1 day pregnant. That was as of October when she initially presented to us, with a past medical history of diabetes type 2 on insulin and asthma. On the right side of your screen, you'll see her echo from July 27th of 2023, where you can see that she had a normal LV function and no evidence of valvular abnormalities. I just picked two images to really show you a 4-chamber and a peristernal long, but you can see that it was very normal at that time. She had some microcytic anemia on her recent lab work, and that was commented on by OB that was normal with her pregnancy. And she had a chief complaint of 1 day of diarrhea and abdominal cramping and was found to have diabetic ketoacidosis. She was admitted to our MICU service for management of the DKA, including insulin drip and volume resuscitation. However, this was complicated by emergent cesarean delivery in the L&D OR for fetal bradycardia. So while in the OR, the patient had a PEA and asystole arrest requiring ACLS and eventually via ECMO cannulation. She received multiple rounds of CPR, including also epinephrine, bicarbonate boluses, calcium boluses. She developed coagulopathy and suspected DIC, requiring massive transfusion protocol. And so at the end of all of her resuscitation, we had obtained RAW. She was on VA ECMO. She was admitted to 7 ICU on VA ECMO as a bridge to further decision-making. And on the right side of your screen here, you'll see her echocardiogram on VA ECMO at 2.8 liters per minute. So you can see that, certainly compared to the echo of July, she's had major changes at that time. Okay, we'll come back to that case in a few minutes as we discuss maternal mortality in the US. And I put this graphic here from the CDC Pregnancy Mortality Surveillance System to show us that maternal mortality has been rising in the US over the last 30 years. And notably, the US has the highest maternal mortality ratio of all of the developed countries. So this is really, really important information. You can see on the left side of your screen here, this is a schematic from the NIH. The US has the highest maternal mortality ratio of all the developed countries, you can see. On the right side of your screen, you can see that Blacks and American Indians, Alaska Natives are at the highest risk for maternal mortality in the United States compared to other ethnic groups. And so the NIH has really prioritized research to identify risk factors and explore disparities in care and is working on developing treatments to really improve maternal health and outcomes, but really more action is needed to make pregnancy and childbirth safer in the United States. So this is data from the NCHS Healthy Stats from 2022, and it shows the maternal mortality rates by race on the left side of your screen. You can see that by all categories, all races, maternal mortality has increased in the US, and this is for the years 2018 to 2020. So you see 2020 on the right in purple and 2018 on the left in blue. And then on the right side of your screen, you can see that maternal mortality rates have also increased by age group during the same time frame, again, across every age group. So the under 25, the 25 to 39, and the 40 and over age group as well. So this is really significant. So why is this important, right? To give a bit more background, it's important to know that cardiovascular disease is now the leading cause of death during pregnancy and the postpartum period. And additionally, with advanced maternal age and delayed childbearing, underlying medical conditions like hypertension, diabetes, high cholesterol have been more common and have increased the incidence of acquired heart disease complicating pregnancy as well. So this bar graph is from the CDC Pregnancy Mortality Surveillance System as well. And I just want to bring your attention to the two bars on the far left of your screen, and then the third one in from the left of the screen as well. So if you can see, cardiovascular conditions and cardiomyopathy are responsible for 14.5% of pregnancy-related deaths and 12.1% of pregnancy-related deaths in the United States from 2017 to 2019, respectively. And so this, again, highlights the need for us as cardiologists and as clinicians to be aware of what we need to do to make maternal health care safer and have better outcomes for our patients. I put this in here. This was actually a AHA policy statement that came out in 2021 from the American Heart Association, supported by the American College of Obstetricians and Gynecologists. And actually our own Dr. Carol Watson was a part of this policy statement. And this really highlights the need to address inequalities and social determinants of health to help facilitate maternal health equity, which actually in my mind should be really standard in this day and age. But as you can see on the left side of your screen, we need to be thinking about these vulnerable populations and the social determinants of health while we're providing clinical care for them so that we can achieve every woman to have a fair and just opportunity to have healthy prenatal care, labor and delivery, postpartum care, and a safe neonatal outcome as well. And on the right side of your screen, you can see there are many ways that we can try to work together to advocate and create true positive change towards this maternal health equity. And I really want to challenge each and every one of us to be a part of this transformation in care and delivery. So with that being said, now that we have an understanding of the background and the need and really the urgency, and we have a call to action, let's talk about what cardio-obstetrics is and delve right into all of the things that you need to know. So what is cardio-obstetrics? So we define cardio-obstetrics as a multidisciplinary team of clinicians that are focused on pregnant patients from preconception through the postpartum period and beyond. And when you think about key team members from a multidisciplinary perspective, we think about physicians and surgeons, cardiologists, OB, MFM, anesthesiology, CT surgery, pediatric team members, pediatric cardiology, neonatology, pulmonary hypertension team members, congenital heart specialists, our primary care specialists, our cardiovascular team members, our mental health specialists, our nurse specialists and physician assistants, and pharmacists and geneticists too. So it really takes a village to take care of these patients, and I want to highlight that in this slide. In the cardio-obstetrics world, we really refer to 6 critical time periods across what we call the reproductive continuum. And those periods of time are considered 1, preconception, 2, pregnancy, 3, labor and delivery, 4, immediate postpartum, 5, what's been considered the 4th trimester, and then 6, really the long-term follow-up care for these patients. So we'll go into each one of these in a little bit more detail and talk about what we can do to assess these patients first. So this is an algorithm that came from Circulation Heart Failure back in 2021, which highlights cardiovascular risk assessment in the pre-pregnancy period. 2 of the most important questions that are highlighted are, number 1, is your patient considering conception? And number 2, are there contraindications for conception? And you can see going down this algorithm, if your patient is considering conception, yes, what are the things that we recommend doing? Performing a complete history and physical examination, including history about, for example, prior chemotherapy or chest radiation, getting echocardiographic data if needed, and assessing the risk scores, which we'll talk about in the subsequent slides. If the answer is no, then definitely confirming a contraceptive plan, understanding their modified WHO class to guide risks about contraception, and really having shared decision-making conversations about temporary versus permanent contraceptive methods would be very important. And then the second major question is, are there contraindications to conception, right? So ideally, we like to have these discussions before the patient has conceived, but if there are contraindications after conception, then certainly it becomes a discussion about termination if conception has already occurred, and a further discussion about contraception. And if there are no contraindications to contraception, then certainly referring to cardio-obstetrics clinic, reviewing teratogenic medications, considering appropriate, genetic counseling depending on the etiology of the cardiomyopathy would be important too. I want to bring your attention also to the bottom left side of your screen here, where you can see the frequency of cardiac assessment during pregnancy that's recommended by the modified WHO class. So for class 1, 1 or 2 visits during pregnancy is considered appropriate. Class 2, 1 visit per trimester. Class 3, really monthly or bi-monthly, and class 4, or if unplanned as well, monthly follow-up. And we'll go into the risk criteria a little bit more on the subsequent slides. So I want to just take you back for a moment to the hemodynamic changes of pregnancy, because we don't always deal with this unless you see patients in a cardio-OB clinic or you deal with this on a frequent basis. So remember that when a patient becomes pregnant, the hemodynamic changes of pregnancy occur quickly and are sustained through the 2nd trimester, and then return largely to non-pregnant levels by just 2 weeks after delivery. So the changes happen quickly at first, they're sustained, and then they return to normal by very quickly after delivery as well. I want to also note that pregnancy is often called nature's stress test on the body due to the number of physiologic changes that occur during this time. And you can see that on the left side of your screen here, that with early pregnancy, you have an increase in cardiac output, stroke volume, and heart rate, and a pretty rapid decrease in the SVR, the systemic vascular resistance, as well. So I'm going to go into the details of that on the next slide, just to highlight the things that I want you to remember. So in the 1st trimester, systemic vasodilation becomes apparent as early as 4 to 6 weeks of gestation. This decrease in the peripheral vascular resistance is sustained through the middle of the 2nd trimester. And the estimate is that it's a drop of about 40% or so at the nadir. The 2nd trimester, the cardiac output continues to rise, and it's in a non-linear fashion. And the sharpest rise in cardiac output really is at the beginning of the 1st trimester, but that increase does continue into the 2nd trimester as well. And then the heart rate in the 3rd trimester rises throughout gestation, but it's peaking in the late 3rd trimester, usually 10 to 15 beats per minute above non-pregnant values. So let's talk just a minute about risk stratification in pregnancy. On the left side of your screen, you will see predictors of adverse events in pregnant women with heart disease. And this was an article that came out in JACC back in 2018. But knowledge of patient history, exam, and the cardiac lesions that they have is really of the utmost importance because you can see that all these factors are predictors as well of adverse events in pregnant women with cardiac disease. In the middle of your screen, you'll see the WHO classifications, who 1, 2, 3, and then on the bottom of your screen, this is the one to really remember, group 4, where pregnancy is not recommended. So I really want to bring your attention to this portion in the middle here of your screen where pregnancy is not recommended. And on the right side of your screen, you can see the Zahara risk score, which was largely derived from the adult congenital heart population, but has also been extrapolated to the general maternal cardiovascular disease population as well. So now let's talk a little bit about the differential diagnosis for heart failure in pregnancy. We often think about peripartum cardiomyopathy, which I'm going to discuss in the subsequent slides as well. But remember that peripartum cardiomyopathy is a diagnosis of exclusion, right? So it's important that we as clinicians, when we see these patients, consider other cardiomyopathies in our differential, and we perform the appropriate history, physical exam, lab, imaging, genetic testing to exclude other causes prior to labeling a patient with a diagnosis of peripartum cardiomyopathy. And so on the left side of your screen in this schematic from circulation heart failure, you can see some of the common cardiomyopathies in pregnancy. In the blue, you see the peripartum cardiomyopathy. In purple, you see hypertrophic cardiomyopathy. As well as you see stress cardiomyopathy, dilated familial cardiomyopathy, chemotherapy-induced cardiomyopathy, LV non-compaction. And on the right side of your screen, this schematic is from a JACC paper in 2020 that just highlights the wide differential that exists for heart failure during pregnancy, and just also bringing attention to other causes, right? Like myocarditis, for example, like valvular heart disease, tachycardia, arrhythmia-mediated cardiomyopathy, pulmonary embolism, cardiomyopathy related to other systemic diseases. So really important to think about all of those things in your differential prior to labeling somebody with peripartum cardiomyopathy. So the 2022 heart failure guidelines from the AHA, ACC, and the HFSA did include recommendations for heart failure in pregnancy. So the class 1 recommendation was that in women with a history of heart failure or cardiomyopathy, including previous peripartum cardiomyopathy, patient-centered counseling regarding contraception and the risks of cardiovascular deterioration during pregnancy should be provided. And then there was a class 2B recommendation that you can see in the middle of your screen, which said that in patients with acute heart failure caused by peripartum cardiomyopathy and an LVEF less than 30, anticoagulation may be reasonable until 6 to 8 weeks postpartum, although really limited data on efficacy and safety. And then class 3, or risk of harm, patients who have heart failure or cardiomyopathy who are pregnant or currently planning for pregnancy, making sure that we avoid agents that could cause significant fetal harm. Okay, and we'll go into that also in the next few slides. So let's now focus on peripartum cardiomyopathy. How do we define peripartum cardiomyopathy? So it's a non-ischemic cardiomyopathy with a reduced LVEF, less than 45%, typically presenting at the end of pregnancy or early in the postpartum period. Ventricular dilation may or may not be present. And as I've told you a few times before, one of the key takeaways is that this is a diagnosis of exclusion. Okay, delayed diagnosis often occurs, though, due to the symptoms of heart failure mimicking those of normal pregnancy. The pathophysiology of this disease process is really not well understood and thought to be likely multifactorial. There's some thought that there could be a genetic predisposition, noting that up to 15% of these patients have gene variants associated with DCM. So it's definitely still not well understood, and more research needs to be done into this to really understand this. And on the right side of your screen, you can see some of the biomarkers that we analyzed in patients with peripartum cardiomyopathy as well. So the incidence of peripartum cardiomyopathy has reported ranges between 1 in 1,000 and 1 in 4,000, and really may be increasing. This is thought to be due to a rise in the maternal age, increased rates of multifetal pregnancies, right, due to contemporary fertility techniques, increased recognition of the disease among clinicians, but many cases may still be unrecognized and undiagnosed. So the true incidence is really unknown. And I think one of the other key takeaways is that the outcomes are really variable. Women can have complete recovery, they could have persistent myocardial dysfunction and heart failure, or they could have rapid deterioration, leading to the urgent need for temporary or durable MCS or transplant considerations. So, when we think about treatment of peripartum cardiomyopathy, we really have to think of it as a therapeutic spectrum, depending on how ill the patient is, right? So, we define peripartum cardiomyopathy between spectrums of mild, moderate, and severe. And you can see that on the right side of your screen. You can see in green, mild, yellow, moderate, and severe in the orange on the right side of your screen. So, therapy really varies widely from oral heart failure drugs for patients with a mild peripartum cardiomyopathy to urgent MCS and consideration for transplantation with those patients who have severe peripartum cardiomyopathy and cardiogenic shock. I want to bring also attention to the fact that the long-term outcomes remain largely unknown. So optimal duration of medical therapy is really unknown as well, and close surveillance is necessary even for those patients who do have recovery of their LV function. Okay. This slide I wanted to use to highlight common heart failure medications that we use and their safety during pregnancy and lactation. On the right side of your screen, you can also see some of the cardiovascular medications that we use for other conditions like arrhythmias, hypertension, pulmonary hypertension, anticoagulation, and those that are contraindicated in pregnancy are there on the bottom right side of that schematic in red as well. I want to also just note that the FDA pregnancy categories are really no longer routinely used. And so it's recommended that data for each medication should be reviewed really carefully by each clinician and with each patient, utilizing tools or resources like LactMed, for example, as well. All right, so this schematic from ESC highlights recommendations for chronic medical therapy in patients with peripartum cardiomyopathy, and also some recommendations for the duration of drug therapy and assessment of recovery as well. Notably, on the right side of your screen there, you can see that even if a patient does have complete and sustained recovery, this was defined as an LVEF greater than 55% and NYHA functional class 1 in terms of symptoms. It was recommended to continue all drugs, so continuing beta blocker, ACE, ARB, ARNI, MRA for at least 12 to 24 months after full recovery, and individualizing the approach and having a shared decision-making conversation with each patient. The recommendation was that if it was determined to discontinue a goal-directed medical therapy, then to discontinue it in a stepwise function, monitor symptoms and LV function at each step along the way as well. So when we evaluate patients on pharmacotherapy for peripartum cardiomyopathy, I wanted to just remind us that we also have to consider the effects of these medications on other organ systems and the pharmacokinetics of each drug as well. So you can see here on the left side of your screen, thinking about how these drugs affect absorption, bowel motility, how they affect the lung function, minute ventilation, tidal volume, respiratory rate. Is there an effect on uteroplacental flow or fetal metabolism? Is there an effect on the kidney in terms of GFR, secretion, reabsorption, renal clearance? These are all really important things to think about as well, including volume of distribution as well. So oftentimes patients come to our clinic asking, what is the risk of a subsequent pregnancy? And that's often a really difficult thing to quantify, right? So I highlight that here shared decision making is key, considering all risk factors and events leading up to this point. However, there is data suggesting that the risk of fetal complications is extremely high if the EF is less than 50%. And this was published in JACC in 2014 by Dr. Al-Qayyam from USC. One of the things that we think about when patients come to us requesting consideration for subsequent pregnancy is very close clinical assessments. So we want to assess them with seeing them in person, history and physical, echo, and BNP at really regular intervals, and definitely if they have any concerning symptoms in between these timeframes as well. But certainly thinking about the timeframe prior to conception, at the end of first trimester, at the end of second trimester, about a month prior to delivery, after delivery prior to discharge, and then a month after delivery as well. Some of the things that we can do for these patients with peripartum cardiomyopathy as far as postpartum care can be early postpartum visits and frequent adjustments of medication, discussion on contraception, counseling on future pregnancy risk. Importantly, also discussing depression and anxiety and things that happen with the hormonal shifts postpartum as well. And then thinking about the long-term cardiovascular disease risk modification as well. And then thinking through specific interventions, thinking about cardiac rehab if they have poor functional capacity, thinking about advanced interventions, referring to cardiomyopathy specialists if their heart function remains decreased, thinking about valvular intervention if needed, arrhythmia, ablations or devices, and then certainly blood pressure management is really key as well. So I wanted to also highlight contraception here. This is a one-slide primer on contraception because this is not the main focus of today's talk, but an important piece nonetheless. I wanted to highlight this website here, reproductiveaccess.org. It has a great PDF resource which goes through all the different types of contraception. On the right side of your screen, I just screenshotted one particular page from this. But it really is very user-friendly, talks about how we as clinicians can counsel our patients about appropriate contraception. And on the left side of your screen, you can see a summary of recommended and contraindicated contraception options for women with cardiomyopathy. So in terms of patients with low EFs, really IUD has been preferred as the first longer-term reversible option in patients with reduced EF. And notably, barrier methods are really not recommended because they're really unreliable and insufficient as a sole method of contraception. Okay, so now that we've talked about all of those things, let's talk about MCS and transplant and pregnancy. Notably, most of the studies that are here are very, very low numbers of patients, as you might imagine. This study was published from the Euromax database, looking at 16 patients with peripartum cardiomyopathy and consecutive LVAD placement between May 2011 and September 2018. And notably, most of these patients had MCS initiation within a month of the peripartum cardiomyopathy diagnosis. So 6 out of those patients had the device placed within a month. And notably, most of them were Intermax profiles 1 or 2, with 2 being the most common. So they were really, really sick at the time of these implants as well. Notably, most of these patients also had HVADs placed, and I want to bring attention to that because the HVAD device is actually under an FDA recall now since 2021 due to intermittent pump stoppages. So it's no longer being implanted, but some patients may still have that device. But this study was initially done in 2011 to 2018, which is probably why a large majority of them had the HVAD placed. And perhaps also if some of these patients were smaller from an anatomical perspective, the HVAD may have been a better choice for them at that time. I also want to highlight the follow-up for these patients that 6 of these patients, so 6 out of the 15 patients that were follow-up data completed, went to transplant, and ultimately 10 out of 15 also had complications from driveline infections as well. This study here that was done looked at a retrospective analysis of data from peripartum cardiomyopathy patients undergoing LVAD implantation in 2 tertiary centers, assessing long-term outcomes for this population. And again, just bringing your attention to the fact that there were only 12 patients that were included in this study with a mean age of 30 years. 8 of these 12 patients were defined as intermax class 1, so that really crashing and burning patient who needs intervention really within hours at the time of implantation. And most of these patients also received HVADs. And again, notably, the time from the peripartum cardiomyopathy to LVAD implantation was less than 1 month in 7 out of 12 of these patients in this paper. There have been a few case reports of pregnancy with an LVAD device, but again, these are fairly few and far between. And most of these patients, again, have been implanted with a HeartMate 2 or an HVAD at that time, again, probably related to the fact that these case reports have really been between 2011 and 2019, and you can see that on the right side of your screen there on the blue table. So what are the key takeaways that I want you to remember? So many patients are really younger, presenting with peripartum cardiomyopathy and requiring temporary mechanical circulatory support as a bridge to further decision-making. This really mirrors the trend that we're seeing in other non-peripartum cardiomyopathies or non-pregnant shock patients. These patients are often sicker on presentation, so they have a higher intermax class. And again, this limited case series from Europe and the Middle East suggests a trend towards needing transplant post-LVAD, but these are very, very small numbers, so it's really hard to extrapolate or generalize based on these very, very small numbers. And because this is a really limited data zone to guide decision-making, multidisciplinary consensus at each center is really key. And so when we have these patients come up, like the patient that I discussed at the beginning of the talk and that will follow up shortly towards the end of the talk, we talk about these patients frequently in our heart failure selection committee meetings to really make sure that we're getting a consensus. On the right side of your screen, you can see, some of the important takeaways for pregnant women who are on LVAD support. So thinking about hemocompatibility events like bleeding and device thrombosis, which the risk can be much higher, and hemodynamic consequences, right? The risk of RV failure is quite high. There could be risk of uterine compression of the LVAD components, and then also effects on the cardiac output as well. So let's now switch gears to talking about pregnancy post-heart transplant. So again, very limited data in this area, but I wanted to highlight this article that came out in Circulation Heart Failure back in 2020, looking at survey results from 122 heart transplant healthcare team members. And the goal of this survey was really to explore attitudes, practices, and center policies surrounding pregnancy in transplant recipients. Notably, here you can see on the right side of your screen, 31% of these 122 heart transplant healthcare team members thought pregnancy should be avoided for all. 2% thought pregnancy was feasible in all, and 67% felt like there's probably a gray zone, right? Pregnancy is feasible for select women, but should be avoided in others. The commonly reported contraindications to pregnancy were things like a history of rejection or reduced LV function, presence of donor-specific antibodies, cardiac allograft vasculopathy, non-compliance, significant concerns about contraindications to pregnancy with that. And then history of peripartum cardiomyopathy pre-transplant also was a commonly reported concern. In terms of immunosuppression regimens that are recommended during pregnancy, 68% of these survey respondents suggested calcineurin inhibition alone, while 29% suggested calcineurin inhibition and prednisone combinations, with much smaller numbers suggesting other combinations that you can see on the right side of the bar graph. So in terms of recommendations from our societies, the ISHLT recommends that there's a baseline assessment of graft function before conception with an EKG, echocardiogram, and coronary angiogram if it has not been performed within the previous 6 months, and then also consideration on an individual basis for a right heart catheterization biopsy. The American Society for Transplant consensus statement says that transplant recipients in the past, considering pregnancy, should have had no rejection in the past year. They should have stable graft function and stably dosed immunosuppression as well. On the left side of your screen, I highlighted some of the common medications that we use from the ISHLT 2010 guideline recommendations, and just really want to bring the attention to the fact that anti-metabolite therapies, right, like mycophenolate, azathioprine, really should not be used in pregnancy. And I'll highlight some of the fetal malformations that you can see in a couple of the subsequent slides. Also, there has been concern about mTOR inhibitors as well due to concerns about wound healing. And while we reserve cesarean section really for obstetric indications, we have sometimes transitioned patients off of these mTOR inhibitors in the event of needing an urgent cesarean section for obstetric indications. These are the ISHLT recommendations in a little more visual form for reference. And then I just wanted to highlight here the Transplant Pregnancy Registry. That is a real great resource that talks about multi-organ transplant and pregnancy. So there's information for every single organ: heart transplant, lung, kidney, liver, pancreas, contraception, breastfeeding, management of transplant recipients. So this is a really good resource that I have used when I'm counseling our post-transplant patients about pregnancy. Notably, in this registry, there were 3,039 total recipients, and this was data as of August of 2022, so there may be even more at this time. The large majority of the data is coming from USA, with much smaller numbers coming from other countries worldwide. I want to highlight here the reason why we should take patients off of mycophenolate, because the risk of birth defects is really significant, as you can see here on this slide. In terms of thoracic organ recipients that were in this transplant pregnancy registry, there were 110 heart transplant recipients and 187 pregnancy outcomes, and that included multiples pregnancies as well. And notably during pregnancy, big things were these heart transplant recipients did have hypertension and preeclampsia. Only about 8% of the patients had rejection, and also notably within 2 years of delivery, the rate of graft loss after having a pregnancy was only 2.7%. So, important to have this shared decision-making conversation with our patients with this type of data at hand when we counsel them, including, their specific scenarios, but also telling them that this has happened before. Patients have been able to have successful pregnancies if that's something that's important to them. This data here is also from the Transplant Registry International, showing the newborn outcomes for heart and lung transplant recipients. So notably, a lot of them did have low birth weight, and a fair number, 32%, had late preterm deliveries between 32 to less than 37 weeks. So the risk of preterm delivery is real. Cesarean section was also approaching almost 50% for these patients and newborns as well. So that's really important to know. The trends in breastfeeding practices have actually increased over the last decade or so. So this data shows that many of our patients post-transplant have actually been able to breastfeed if they so choose. This data shows, this is a paper from 2013, looking at tacrolimus levels in blood and breast milk. And tacro levels actually were fairly similar. And the infant exposure through breast milk was really less than 0.3% of the mother's weight adjusted dose. So I think that's important information, again, to be able to use when we're counseling our patients. I've included some helpful links from the American Society for Transplant here on pregnancy and transplantation, and a little bit on immunosuppression and therapeutic drug monitoring during pregnancy for reference here as well. When we see these patients as part of a cardio-obstetrics preconception evaluation post-transplant, here are some of the things that we do. We get a patient and partner HLA to understand if there could be a risk of pregnancy propagating rejection in the transplant recipient. We make appropriate pharmacotherapy adjustments pre-conception. We make sure that the patient is up to date on preconception surveillance testing. We have a discussion with all of our key medical stakeholders, again, including that multidisciplinary team that I highlighted the importance of. And we also educate our patients on alternative methods of family planning. So we really collaborate with our OB MFM colleagues on this as well to educate them on all of the different options that exist for them. Again, this paper was from 2020, talking about pregnancy outcomes in heart transplant recipients specifically. So from 1987 to 2016, there are records of 91 female heart transplant recipients with pregnancies who were enrolled in this voluntary transplant pregnancy registry. Notably, an average span from transplant to conception of about 7 years. One of the things that I think could use, some work is the fact that 46% of these pregnancies were unplanned. So I think that's a really important area where we can make a difference. And then also, 26% of these patients did have miscarriages, a much higher number if the patient was on mycophenolate previously versus not. And then 13% of those patients in this registry had severe rejection in the interpartum periods, and 10% in the 3-month postpartum period as well. So these are, again, things that we have to really be careful and discuss with our patients, noting their individual history of rejection, their individual journey to transplant, their medical history as well. So what are the takeaways for pregnancy post-heart transplant that I want you to be familiar with? Limited recommendations, right? A lot of these are consensus statements from the ISHLT and the AST. The ISHLT recommendations were actually from 2010, so long overdue for an update. The data that exists is really primarily from case report theories and really voluntary registry participation. And there seems to be significant variability still in practice pattern and center-specific protocols. But with improvements in post-transplant care and advances in immunosuppression, this is going to be an issue that we need to be prepared to safely address, because women of reproductive age are undergoing transplant more frequently, and they are living longer. On the right side of your screen, you can see some considerations or just highlights from circulation heart failure about patients who are wanting to get pregnant after heart transplant. So really remembering avoiding pregnancy when those patients with reduced ejection fraction or severe cardiac allograft vasculopathy, vaginal delivery preferred with regional anesthesia to minimize fluid shifts, and C-section reserved for obstetric indications. And really, again, highlighting, emphasizing that patients should be on a stable immunosuppressive regimen and at least 1 year out from transplant prior to conception. So let's now switch gears just a little bit to talk about labor and delivery and peripartum considerations for patients with a history of cardiac disease. So we really have to think here about the intersection between the patient, the disease process, and the pregnancy, right? So we have to think about the patient. What's their volume status? What's their blood pressure? What's their heart rate? What's their body positioning? Have they had children before? What is their disease status? What type of lesion do they have? What is the severity of the lesion? What's their ventricular function? What other comorbidities are affecting them? And then we have to think about the pregnancy. What is the gestational age? What's the fetal size? What is the mode of delivery? What is the blood loss that's anticipated? And what kind of obstetric medications could be used safely? We often consider an induction of labor at 39 weeks for all patients with a history of cardiac disease. Again, vaginal delivery, preferred method of delivery for most patients. And I think it's really important to also highlight the written care and delivery plan that I'm going to show you on the next slide, and reviewing that with the multidisciplinary team. And this is something that we're doing in our cardio obstetrics team now. Our own Mary Canobio and Dr. Afshar wrote this up and published it in the International Journal of Cardiology back in 2022, highlighting this delivery plan with the patient risk category. What are the things that the patient is at risk for? What are the things that we want to do upon admission? And the delivery management and recovery, postpartum discharge planning as well. So having this in place and having a multidisciplinary discussion about this preemptively has really helped with improving our care delivery and our outcomes for these really complex patients. When we think about peripartum care as well, we need to make sure that the patients are in an appropriate center that can handle their level of complexity. So really making sure that these patients, for example, who are modified World Health Organization class 1, 2, 3, or 4 are in the right location that can take care of them. So for example, the level 4 regional perinatal health center really can take care of the most complex maternal health conditions. We have ICU care with maternal fetal medicine co-management. We have cardiac surgery, ECMO, transplant capabilities. And so it's just really important to keep that in mind as well when we're talking to these patients about delivery, where to deliver, because many patients come to us from places that are farther away. All right, so some of the other peripartum considerations should be thinking about the side effects of medications that are commonly used for obstetric care. So medications like oxytocin, medications like terbutaline, medications like or uterotonic medications like methylorganavine as well, and how they affect the SVR, the MAP, the pulmonary vascular resistance. That's really important for us to be aware of as well. So of course, each of this is going to be different for each patient depending on their particular cardiac history, but that's something that we also include in our delivery plan as well. As this medication may be considered, or this medication may need to be contraindicated in this particular patient due to their cardiac history. So this schematic is from the California Department of Public Health, and it just highlights red flags that should prompt an evaluation or hospitalization for acute symptoms. So big red flags: shortness of breath at rest, severe orthopnea greater than or equal to 4 pillows, arresting heart rate greater than 120, arresting systolic blood pressure greater than 160, arresting respiration rate of greater than 30, O2 sats less than 94. This should prompt an evaluation and or a hospitalization for acute symptoms. In consultation with MFM, primary care, cardiology as well. This also came from the California Maternal Quality Care Collaborative. And really what they identified is that 88% of cases would have been identified as high risk of cardiovascular disease in asymptomatic women, and 93% of symptomatic women that would have prompted further testing. So just really wanted to make sure that I highlight the fact that it's the combination, right, of the symptoms, the vital signs, the risk factors, the physical exam that should prompt further assessment: EKG, BNP, possibly echocardiogram, chest X-ray, consult with MFM, primary care cardiology as well. So I put this in for reference as well. So so far, we have talked about most of the critical time periods. We've covered preconception, we've covered pregnancy, we've talked about labor and delivery, we've talked about immediate postpartum, we've talked about that fourth trimester. Now let's talk for a few minutes about long-term considerations, okay? So adverse pregnancy outcomes contribute to the long-term potential for development of disorders of the heart and vascular system, including coronary artery disease, cardiomyopathies, and arrhythmias, okay? Adverse pregnancy outcomes have been associated with future maternal cardiovascular disease, and you can see this across the board. You can see this with hypertension, cardiovascular disease, ischemic heart disease, stroke, heart failure, diabetes. These are really important things to keep in mind. And so when we see these patients, we really need to be prepared to care for them throughout the reproductive continuum and really prevent these complications and keep these considerations in mind when we're caring for these patients. So what should future visits focus on? Future visits with cardiologists and primary care providers need to focus on contraception, risk of future pregnancy, as well as long-term cardiovascular risk assessment, modification for lifestyle changes, and also pharmacotherapy as well. So it's really, really important for these patients that they get a full comprehensive cardiovascular risk screening within 3 months postpartum, including an updated medical history, a physical examination, and laboratory testing too. There are significant gaps in care for women compared to men in every area of cardiovascular medicine. So it's really imperative that we address these disparities to optimize cardiovascular outcomes for women, okay? So now that we've talked about all the aspects of the reproductive continuum, we've talked about mechanical circulatory support, we've talked about pregnancy, post-heart transplant, we've talked about peripartum cardiomyopathy. I want to take you back for a minute to this patient that I talked about at the beginning. So what happened to her? So the patient was stabilized on VA ECMO and had an Impella 5.5 placed as a bridge for further decision making. She was eventually able to be decannulated for ECMO after 1.5 months of stabilization and treatment with inotropic support, with antibiotics, with many different things. And she continues to remain on Impella 5.5 and inotropic support for her ongoing heart failure. And this is her most recent echo right now, as of last week. So you can see that with the Impella in, she still has significant cardiomyopathy. So as she stabilized, we actually had her undergo a transplant advanced therapies evaluation in late December of 2023. And since the patient stabilized, but was still Impella dependent and really an optimal candidate for LVAD due to RV failure, patient sizing, and her degree of sensitization, we decided to discuss her as a potential candidate for transplantation, knowing that it would be difficult because she's so highly sensitized. As you can see on the screen here, her CPRA was 99.94% for all antibodies, which is very, very significant. And we knew that it would be like finding a needle in a haystack for her if we were to find a organ offer immediately. But given the fact that she was ambulating, she was on Impella alone, she had really become optimized from a nutritional perspective and from a wound healing perspective, we listed her for OHT just a few weeks ago with plans of concurrent desensitization with daratumumab, which she's undergoing right now, and she's currently awaiting organ offers while in the 7 ICU. So we'll see what happens with her, but this is just an example of one of the many complex patients that we take care of. I want to highlight for a moment here a UCLA Cardiobstetrics collaboration and our future directions. We're really working to optimize our clinic and align with our MFM colleagues to see patients on the same day if possible. And that's really been something that we've been able to make a reality as of July of this past year in 2023. We also want to take a really deep dive, into educating our fellows and our trainees and our cardiovascular team members about this area so that we can, be able to provide the most optimal care for these patients and really work towards maternal health equity, as I showed you before in the slides, addressing these social disparities of social determinants of health and addressing these disparities that are present for these vulnerable populations. So overall, if you take away nothing else from this talk, what do I want you to remember? I want you to remember that subsequent pregnancy after peripartum cardiomyopathy is associated with a risk of relapse. Red flag symptoms, vital sign derangements, and abnormal exam findings in a peripartum woman need to warrant further cardiac evaluation. That should be like warning bells going off in your head. Adverse pregnancy outcomes increase a woman's risk of long-term cardiovascular disease. Refer these high-risk patients early. A multidisciplinary cardio OB team is key to successful outcomes. And then lastly, don't forget about contraception. Really important, not often discussed. With that, I want to just highlight our team members, both from the cardio-obstetrics side, the Women's Health Center, Women's Cardiovascular Center side, the cardiomyopathy team, the VAD team, transplant team, outreach team, cardiomyopathy APNs. We can't do it without you. It takes a village to take care of these patients. And so just want to take a moment to thank those folks that I work with on a regular basis. And with that, I think I will end and take any questions in the last minute that we have available. Otherwise, thank you so much.
Dr. Kamath, that was a fantastic lecture. Currently, for patients who do have gestational diabetes or, these risk-enhancing factors postpartum, is there any way that we can risk stratify if they need like lipids earlier? Because a lot of our risk stratification for these medications for prevention don't include these patients. So how do you usually approach ways to mitigate their risk postpartum?
Yeah, that's great. One of the things that's challenging, right, is that the lipid panels, are things that we usually don't get during pregnancy due to how significantly deviated, they usually are from normal at that time period. So I think one of the best things that goes back to is really prevention, right, and following them closely. There really isn't a lot of data in this arena, but I think highlighting the importance of a preconception assessment, talking to them about this beforehand and trying to optimize that as much as possible. Preconception is really, really important, and then following them closely, of course, during the pregnancy as well. But you're right, that's an area, again, where there's limited data. There's really no guidelines that are written for that. And I think the other thing to highlight too would be the screening after postpartum as well, making sure that they get in closely. And that's one of the other things that we've been trying to do for a lot of our patients is really aligning with the OB providers and seeing them in those really critical fourth trimester time points as well, so that we can, address some of these issues too.
Hey Megan, this is Sonia. Thanks for this awesome talk. Kind of similar to along the lines of what Suthi was asking in regards to like lipid screening and ASCVD risk stratification. Like, let's say you have a patient who is like in their late 30s and you have them on a statin. In terms of like contraception counseling, one, two, like when would you stop the statin in regards to them like deciding to get pregnant?
That's a great question too. Yeah. So a lot of times we're seeing them a couple, like for our population that we see, we're seeing them a couple months in advance, and we're talking to them about this so that it's done in a very controlled fashion. So most of the patients that I have been seeing, we will transition them off over a period of several months beforehand. Usually I would say around like 3 months beforehand is kind of what we've been doing. That has been pretty successful so far. I'm again not aware of any significant data, surrounding particular time frames for that. But definitely an area of need for further investigation and further data.
Thanks, Megan. I'm sorry, one more follow-up question. Is there any type of contraception that you recommend for patients who are at that increased ASCVD risk that are on a statin, or someone who has like FH, and like which ones you would use preferably?
So a lot of the patients that I see, I'm a little bit biased, obviously, because most of them I'm seeing with cardiomyopathy. So I've often recommended IUDs for those patients because, you know, from a cardiomyopathy perspective, that has been one of the safest options. But I also usually encourage them to discuss with their OBGYN provider, MFM provider as well. But most of the patients in my personal practice, you know, I've been recommending IUDs, primarily also because of the cardiomyopathy indication too.
Awesome. Thank you so much.
Sure.
Can you guys hear me? I would also comment, Sonia, that if someone has FH, I think the decision to stop a statin should be discussed in a shared decision-making model, because there's a lot more data coming out that statins may not be as teratogenic as previously thought. And depending on what that patient's lipid panel is, you run some serious risks of cardiovascular events during pregnancy if you come off lipid-lowering therapy. I think, if I'm not mistaken, the FDA actually might have removed the contraindication to statins in pregnancy. I can't remember or applied for that. But there's a lot of observational data coming out that it may not be as harmful. And certainly if you have, you know, LDLs getting in the 150 to 200s before you start pregnancy, and you've had known atherosclerotic disease, you really should consider that. As most things in cardio OB, it's not really a yes or no, or I recommend this or not. It's really, well, you could do this, but these are the risks, and we should talk about what you want to choose.
That's really helpful. Thank you, Nadine.
Yeah, that's a great point. But for sure, shared decision making, I think, is the big thing to highlight, because there's really just limited observational data in this patient population primarily. So I think that was also a good point to reemphasize, Nagin. So thanks for adding that.
One last question, if there's time, and I apologize if it was alluded to earlier, I might have missed it, but you know, the limited exposure that I've had to cardio OB is typically, you know, inpatient service, OB-GYN, you know, a B NanCP or troponin was ordered, and you know, it's mildly elevated. And maybe it's a loaded question, but maybe you could comment on, you know, is it ever normal for a troponin to be greater than 99% upper reference limit in pregnant women, you know, BNP threshold, all those sorts of things.
So there is data on BNP abnormalities being concerning in this population. I can send that out to you at a later time. I didn't have time to include it in today's talk, but there is data on that. And then the second question, I'm sorry, was about the
Troponin assay, yeah.
And the question was, I'm sorry.
Is it normal
there's
for a
data
troponin? Is a mild troponin leak ever normal in pregnancy, or is it always pathological?
Again, I don't think that there is a lot of data on that, but I think that it would probably be something that we would need to investigate on an individual patient by patient basis. And I want to just highlight that Nagin put in the comments there, and there's a great paper on this that I'll link to as well. I can send out that while BNP does rise during pregnancy, it should not be abnormal. So anything over 100 is concerning. So I'll put that, there's a paper on that I can send out to you guys.
Thank you.
Sure. Okay, well, thanks everyone. And then stay tuned because hopefully Nagin will do a part 2 next.